we go. I think that should be working now. Yeah, there we go.
Is the slides have disappeared.
Yeah.
Okay, lovely. So the aim of the NHS Smoking Cessation Service is to support delivery of the prevention ambitions in the NHS long-term plan, and for community pharmacy to become a nationally available choice for patients to access smoking cessation support post-discharge. Could I have the next slide, please? So the Smoking Cessation Service is an advanced community pharmacy service, and that follows on from the Smoking Cessation Transfer of Care pilots, which started in October 2020, with the first pilot site being the Royal Oldham Hospital, which made referrals to 12 community pharmacies in the Oldham area. The pharmacies were selected following an expression of interest process, and it was important that the pharmacies gave good geographical coverage as well as extended opening hours. There was also a second pilot site that went live the following year, November 2021, that involved working with Guy's and St. Thomas's Hospital and King's College Hospital. Now, the data from the pilot was used to inform on what the nationally commissioned service would look like. And I should point out that all the pilot sites have now transitioned into the smoking cessation service. Could I have the next slide, please? So what were the findings? So this is data from the Oldham pilot, which ran between October 2020 to December 2021. 201 patients were referred into the service and 81 enrolled in the service. And that equates to a conversion rate of 40%. And this is actually in line with the number of referrals that we're seeing into the locally commissioned service. And the for-quit rate was 57%. And I believe that was actually slightly higher than the locally commissioned service. So that was a really fantastic outcome. And at the end of the 12-week program, 19 patients completed the program. And that equates to the 12-week quit rate of 23%. And I should also mention that 41% of the patients recording a quit at 4 weeks went on to record a quit at 12 weeks. So these successful findings of the pilot demonstrate that community pharmacy are well equipped to deliver on outcomes just as well as the locally commissioned service. Could I have the next slide, please? So following the successful findings of the pilot transitioned into a nationally commissioned service. And this led to a bespoke standard treatment program that was developed with the National Centre for Smoking Cessation and Training. And this is a really important piece of document, and I hope all pharmacists and technicians have read before delivering the service. Following the transition of the pilot to the service funding was agreed between PSNC, which is now known as Community Pharmacy England, and with the NHS England. And so the consultation fees are paid nationally from the Community Pharmacy Contractual Framework, whereas the NRT costs are charged back to the ICB, and the fees from the NRT, the cost from the NRT comes from the primary care prescribing budget. Also, the NHS, the service specification was agreed, and the service was launched to coincide with the National No Smoking Day on the 10th of March last year, with pharmacy registrations opening on the 1st of March. The launch of the service was an intentional soft launch, and that took into consideration that NHS Trust were at different stages in terms of implementing the relevant parts of the NHS long-term plan and having and setting up their inpatient tobacco dependency teams. Could I have the next slide, please? So as mentioned before, the CSU has been commissioned by NHS England to support the implementation of the smoking cessation service. So our role is scoping and mapping and trying to understand the exact position of each trust in terms of their delivery of the relevant parts of the NHS long-term plan. Our role is also to inform planning, identify key stakeholders to support working groups. We also help to facilitate implementation at local levels. Advisors such as myself and Steve are available for each region. We're here to ensure pilot sites transition successfully, to engage with early implementers and those sites looking to start delivery imminently. Our team has also produced supporting documentation and promotional material. Could I have the next slide, please? So what is required for a trust to go live? So it is a three-stage process. Stage one, scoping and mapping. So we try to identify and contact key people at the NHS Trust and have engagement meetings to try and understand their baseline position in terms of setting up their inpatient tobacco dependency services. And once the trust has shown intention to implement the smoking cessation service, then it's important that we have the right sort of people around the table. So that would include OHID, and that stands for Office for Health Improvement and Disparity. We would also have Public Health, LPC, of course, the Acute Trust, and locally commissioned service representatives from the locally commissioned service where one is available. And then we're ready to move on to stage two. This is where we try to understand and establish a referral pathway. And also, the referral mechanism, it has to be a digital electronic referral. So, that is important. And also at this stage, the trust will sort of give an idea when they plan to go live. Once we have a go live date, then we're ready to move on to stage three. And this is the reason we're all here tonight. It's important that we engage with community pharmacy and to ensure that we've got enough sign-ups, so we have good geographical coverage, and that pharmacies are registered and service ready, and they know when to expect to start to receive referrals. And of course, where we don't have enough sign-ups, we seek support from the LPC. So could I have the next slide, please? In terms of the referral pathway, so a hospital inpatient undertaking support quit attempt, when they're due to be discharged, there will be a conversation with the tobacco dependency advisor, and the patient will be given a choice on how they want to continue their treatment. So it'll either be to a locally commissioned service or the community pharmacy smoking cessation service, or the patient may opt for self-care. But it is important that the referral is equitable and it is patient choice. Could I have the next slide, please? So the model of care, and this is taken from the original service specification. So briefly, step one, the patient is admitted into hospital and is identified as an active smoker. And then step two, we move on, the tobacco dependency treatment is initiated with the patient's consent. And then when the patient is ready to be discharged from the hospital, they're given a choice. And the patient obviously decides to select a pharmacy, a registered pharmacy of their choice, where the referral will be sent. So upon discharge, then that referral is sent to the pharmacy. And at step 5, when the pharmacy receives, so whether it's the pharmacist or the technician, the pharmacy technician, they have to act on the referral within 5 working days of receiving that referral. So where contact is made with the patient, and the patient consents to enroll in the service, then the patient transitions fully into the smoking cessation program. And then the pharmacist or the pharmacist technician would sort of agree with the patient, would agree on appointment cycle. And it's important that overlaps with the NRT supply so the patient doesn't run out of their NRT. And then step 7, the post-event messaging. Pharmacists and technicians are required to provide outcome data as part of the service provision to the referring trust as well as the patient's GP. Could I have the next slide, please? So in terms of training, the pharmacist or the technician has to have undertaken the Stop Smoking Practitioner Certification by the NCSCT. If you've already completed that, then you do not need to repeat it. So once you're a Stop Smoking practitioner, you've got the certification, you would need to undertake additional models in order to support pregnant women, patients with mental health problems, and also patients who use e-cigarettes. It's also very important that pharmacists and pharmacy technicians have read the bespoke standard treatment program. It just gives you a more structured approach to your consultations. It also provides effective and evidence-based behavior change techniques to give your patients a good chance of quitting cigarettes. It is also very important that you're competent to undertake carbon monoxide monitoring, and also that you're familiar with your SOP for the service provision. And this is all required prior to signing up with the NHS BCA to deliver the service. Can I have the next slide, please? So just an overview of the service. So firstly, it is intended to complement existing locally commissioned stop smoking services. It is not intended to replace a locally commissioned service. It's to provide additional capacity and also provide, more choice to the patient. You can see patients in the smoking cessation service who have been referred by the acute trust and who wish to initiate and continue a quit attempt post-discharge. So you couldn't see a patient who's just walking into your pharmacy. It has to be a patient who's been an inpatient at the hospital and has been referred by the acute trust. And you will need to make contact with the patient within 5 working days of receiving a referral. And you must make at least 3 attempts, with the 3rd attempt being on the 5th working day of receiving the referral. If no contact is made with the patient, then you are required to inform the trust before closing that referral. So as I mentioned, it is a 12-week program, so you can support patients up to 12 weeks. However, if the patient, for example, had received a week's support while they were in hospital, then the pharmacy or the pharmacist or the pharmacist technician can only provide 11 weeks support. So that is important to remember. Consultations, which have to be done at least fortnightly, can be delivered either face-to-face or remotely, in line with the service specification. And with NRT supply, maximum of up to 2 weeks supply can be issued to the patient. And there is an approved list in the current drug tariff. So that's where you can find, what different formulations of NRT. It's all in the drug tariff. Could I have the next slide, please? A clinical record has to be made on all activities pertaining to the service, and you have to undertake carbon monoxide monitoring for face-to-face consultation. It is really good to do this because it just validates the self-reported smoking status. And also the NRT supplied to patient is completely free of charge, even if a patient pays for their prescription. So that is really important. And also you're required to provide patient level outcome data to the referring trust, as well as the patient GP. And the information required, it's all in the service specification. In terms of fees, so pharmacy contractors would get £1,000 setup fee, and then it's £30 for the initial consultation, £10 for interim consultations, and £40 for the last consultation, which can take place anytime from week 4 to week 12. And you have to make your claims to the NHS BCA via Manage Your Service portal. Thank you. Can I have the next slide, please? So an update on the implementation of the service. So nationally, our team has supported about 43 acute trusts and 3 mental health trusts to go live. We are currently working with a further 62 acute trusts and 11 mental health trusts to help them work towards implementing the smoking cessation service. So in terms of your local area, the trust status, so there's currently 4 acute trusts, 2 have already gone live. So Blackpool went live in July last year, followed by Lancashire Teaching Hospital in November same year, And obviously, the reason we're all here tonight, Morecambe Bay is due to go live on Monday. So it is important that you're all, ready and aware and expecting the referrals, so you're able to act on the referrals in a timely manner. And we're currently East Lancashire, we're working with them, they've engaged with us, and we're helping them to working towards implementing the smoking cessation service. Can I have the next slide, please? And in terms of pharmacy registrations, this is to show, pharmacy registration in your local area. There's about 174 pharmacies registered to provide the service in Lancashire and South Cumbria. And this is taken from our dashboard. So it's a really useful tool, actually, resource. If you visit the Midlands and Lancashire CSU website, there's a dashboard, and there's also a guide on how to interpret the dashboard. It shows trust status as well as pharmacy registrations across England. And if you're only interested in what's going on in the Northwest or in Lancashire and South Cumbria, there's options to do that. Right, could I have the next slide, please? So here's some useful references. And the third link is actually to the dashboard I've just mentioned. If you've not seen it already, please visit our website. There's also some useful resources there to help you, with the service provision. And I think that brings me to the end of my presentation. Thank you.
Thank you very much for that, Jan. Okay, so next I would like to pass over to Anthony and Rebecca.
Evening. So let me put my camera on. So welcome everyone to our presentation on our new inpatient stop smoking service at the RLI and Furness General Hospital. Next slide, please. So after a brief introduction of myself and Anthony, our aim is to just show you how our service is going to work. So we're going to look at the pathway of the patient. So this is from admission to discharge, and then we're going to look at how we access and identify the patients who are current smokers. So we'll use our smoking app on Sequim. We'll look at how us as the stop smoking practitioners capture information from the patient. And then we'll look at the first face-to-face intervention and how we look at how that information is then referred on to the chemists or the quit squad. And then Anthony is going to then look at the data collection and how we get that information post-discharge. Then at the end, myself and Anthony are quite happy to answer any questions. So next slide, please. So my name is Rebecca and I'm the stop smoking practitioner at Furness General Hospital. I've worked for the Trust for almost 7 years now. 18 months ago, I qualified as a registered nurse associate and I worked in outpatients. And then I started this role as the stop smoking practitioner in April. I've completed all the training on the NCSCT courses, and I think that would be quite beneficial for the role. Next slide, please. Anthony.
Yeah, good evening, everybody. My name's Anthony Scott Leach. I'm also a stop smoking practitioner based in Lancaster. Similar to Rebecca, I also started in April. about a week after. I've worked with the NHS for over 20 years, and my previous role was working with the stroke team whilst completing my foundation degree for my assistant practitioner, which I will graduate in July for, and like I say, started the role in April. I've also completed the NCSCT training, and yeah, and I believe we've also got from the trust that Nima, if Nima's here. Next slide, please.
Yeah, I'm here. So I'm Nima Holiker. So I'm the lead pharmacist for medicine and commissioning Crossway. I'm supporting the team to ensure the inpatient supply as inpatients and discharge is done. Hello, everybody.
Thank you, Nima. Next slide, please. So what we've got in front of us, I don't worry about reading it too much, but it's a mapping process. I'm going to focus primarily on the referring nurse or doctor, and the stages that they would do initially before we get to our point of contact, which Rebecca will explain later on. So to the left hand side, so there's a blue bubble that says ask. That's so part of the 3 A's on the very basic assessment. The first thing that we want the referrer to do is to ask the patient if they're a smoker or a non-smoker or ex-smoker, to ascertain a list of patients that have been admitted on that day. Obviously, like, if we can't assess a patient from admission, then obviously when they get referred onto a ward, they can at that point can also be referred to us. At the bottom left, there is a list there of electronic records where doctors and nurses can actually put their referrals through. So there's quite a few options to refer somebody to us. Once they've done that from the 3 A's, once they've done the rasking, obviously that data will be recorded. If it flags up as they're a smoker or an ex-smoker, then part of the advice that we want them to be received is health messages as to the benefits for quitting. Also explain to them that it's a smoke-free hospital, and then also, if they agree to it, have a practitioner referral to ourselves, which is the third A, which is ACT, and that's referring to us via the electronic records that are on the bottom left there. So that the data that they then produce, next slide, please. The data they then produce is similar to what you can see on here. So I was only, when I did this, collected this data, I was only able to get it between the 12th of Jan and the 29th of May, based on current inpatients. So obviously the patients that have been discharged at that point I did the audit, I wasn't able to obtain that data, but just to give you a little bit of look of how it is, we're quite good at capturing patients, as you can see, but there is a little bit of room for improvement. So we've got 74 smokers that were identified across 2 sites. We've got 6 e-cigarette smokers across 3 sites. And we've got 162 ex-smokers, and 260 never smoked. So all those are good. It's good data, but the key ones that we want to improve on, which we've been working on before we go live, we did a talk with the doctors based in Lancaster just last week, and what we're trying to improve the numbers on is the 3 at the end there, which is 7 with history not known, 33 with not given, and 53 not recorded. Obviously, we don't know from those numbers if there was any smokers that wanted to engage with quitting. So that's one thing we're going to strive to improve. But as you can see, the numbers are pretty good. Next slide, please. So what that data looks like in real time to us. So this is just a slide that I've created based on as you can see on the right hand side, the 10th of May, and the number of patients that are actually on there. I've not totaled them up, but there's 19 patients that have got not recorded next to them for the smoking referral. And we've got one ex-smoker that accepted, and we have 2 smokers that declined. So with those numbers there, what we would do from our point of view is we would put them into, as you can see, the right-hand side column there where it says admitted. It's all in date and time order. And what we're aiming to do is trying to see the patients within a 24-hour window. So that would help us to figure out which patients to see in what order, so that we meet that target time. Also with the ex-smokers, I think the statistics are from, if they quit within the last 3 years, there is a quite high percentage that they do return smoking. So they are people that we would like to see, as well as the current smokers. So obviously with not recorded as well, what on the left hand side again, the smoking status, that's where we want to improve our numbers on with how we collect that information from the referrer. Next slide, please. Rebecca.
Sorry, I was on mute. So once the patient has been admitted and the medical team or nursing staff have gone through these 3 steps on the left that Anthony's just mentioned, that ask, advise and act, this is where myself or Anthony come in. So when we first meet a patient on the ward, there's a few things that we need to do. So our main aim, first of all, is to build a good rapport with the patient. The better our relationship is, the more positively the patient will respond. So as you can see on the right, there are some bullet points here that we need to cover with the patient, just to help us get a clear indication of their willingness to attempt to quit. So things like asking the patient about their smoking habit, and we find out a little bit of information regarding the lifestyle, and that will help us work together to come up with ways to improve their habits and routines that will most benefit them in attempting a quit. So we'll look at things like what they smoke. So is it roll-ups, cigarettes, a pipe, how much they smoke, and have they tried to quit before? What kind of things trigger them to smoke? Are they willing to use nicotine replacement therapies, and which ones will be best suited for each patient? Then we need to inform the patients about withdrawal symptoms from nicotine, and also possible side effects of each NRT, so the patient can then make an informed choice. We then go through 6 questions with the patient, and this is called the Fagerström test, and it indicates how dependent on nicotine the patient is, depending on their score. So like I say, 6 questions, and it's scored 0 to 10. So the higher the score, the more dependent they are on nicotine. The lower the score, then they're not as dependent. We also carry out a carbon monoxide test when we first meet the patient, which is just a simple breathing test that measures the volume of carbon monoxide in the lungs. It gives us an indication of if the patient is a light or heavy smoker. So if the patient's a heavy smoker, they're likely to produce a reading over 10 parts per million, whereas a light smoker would probably be between 5 to 10 parts per million. And this is quite a useful tool, as if we revisit the patient in a couple of days and the patient hasn't been smoking, then the result is likely to be lower. So that might be quite a good incentive for the patient to then continue with their quit attempt. So once we've done that, we'll then explain the process to the patient, explaining that whilst they are an inpatient, that it's a smoke-free site, and they're not allowed to smoke on the ward, obviously, and they are discouraged from leaving the ward to go outside for a cigarette, and we would recommend the use of NRT. We then inform the patient that they will be supported after discharge for 12 weeks from the date of our first face-to-face consultation, and it will be a 12 weeks free supply of NRT. Next slide, please. So once we have done the full assessment, we then input the information onto the tobacco care plan, which can be found in clinical charts in the evaluation tab under notes on Lorenzo. Firstly, we document the date of referral. So this is the date of first contact we have with the patient. And then we look at the type of patient contact, location of interaction. So if it's in the hospital, on a ward. And then we look at the type, and if it's a face-to-face, and the length of interaction with the patient. Then we look at the smoking status, so the date of the patient's last cigarette, the scores from the phagosome test and the carbon monoxide score, and when they first started smoking, and how many cigarettes they smoke a day. There's also a free text box, so this is just an opportunity for us to write any comments in there. It's just things like the past medical history, if they're on any medications that may interact with the NRT that's prescribed, because some dosages of medications just may need to be adjusted. So we just need to make just make people aware of that. And then we record the plan. So we record the chosen NRT that will be prescribed as an inpatient, and the NRTs that the hospital pharmacy are providing are the nicotine 24-hour patches, the 7 milligrams, the 14 milligrams, and the 21 milligrams. The nicotine mini lozenges, 1.5 milligrams and 4 milligrams, and the 15 milligram Nicorette inhalator with the cartridges. We will then state where the patient has chosen, if agreeable, to be referred to. So it will either be the local community pharmacies or for Cumbria patients, or Quit Squad for Lancashire patients. So then when the patient is due to be discharged, we'll ensure that the patient is discharged with a 2-week supply of the chosen NRT. And after 28 days, their chosen pharmacy or Quit Squad will inform us of their outcome, which will either be a confirmed quit, self-reported quit, confirmed current smoker, or smoking status unknown. Next slide, please. So when the patient is discharged, the information that we've just then inputted on the tobacco care plan will be completed, and this will be the referral that the pharmacies will receive. So the information that we create will then be saved as a PDF file, and we will email it to the pharmacies via our generic email, which is uhmbstopsmoking@mbht.nhs.uk. We'll show you that at the end, and that will be off myself or Anthony, and we'll specify in the subject field the site of the referral. So we'll either put in FGH or RLI, and then hopefully sometime in the future Westmoreland General as well. So the referral will include the patient's name, address, and we'll make sure that the contact numbers are all up to date, date of birth, RTX and NHS numbers, GP name and address, gender and ethnicity, and also the information that we have collected from having the discussion with the patient regarding like the past medical history, medications, that will be included in the assessment box. I think it's also quite important just to make any comment of any allergies, just in case any of the, the NRTs have any of them, they're allergic to any of the contents. It will then inform you of the NRT the patient was prescribed as an inpatient and what they have been discharged from hospital with. And then just right at the bottom of that page, it will state the name of the stop smoking practitioner, so either myself or Anthony, and also our email address is there as well. So if you need to contact us, and this will be the email address that you use to send the information back to us at of the patient's smoking status at week 4. Next slide.
That brings us on to obviously working in partnership. When we did this presentation, obviously wasn't aware of the information that Jennifer has provided us with earlier about having the information provided to us. One of the questions I was going to ask was how is that currently done with Preston and Blackpool currently?
Yes, that is actually sent. I could probably just answer that for you, but I can pick up offline as well. But those are actually sent direct to the individuals. We actually get a chase, as you already suggested earlier, to send out to the contractor so we know what's going out. And then we also support that chase coming back to yourselves. Just so we have a complete trail, as you've asked the question, that 4 and 12 weeks. But that's part of the service spec as well.
Yes, yeah. And at the time when it was one of the things that we weren't totally sure on, and we spoke with Quit Squad as well, and they're getting back to us on how they waylay their information back currently to Filed Wire and also Lancashire Preston patients. So yeah, it's kind of answered that one really. I was going to use it as a bit of an open forum slide. Next slide, please. And yeah, so is there any questions at this point from anyone?
Should take the silence as you've done an amazing job and fully comprehensive and covered all the questions.
Thank you, Naomi. Oh, we do have one hand up. Yep, sorry. Is it Vipul?
Hi, so yeah, sorry, just a question. I know you mentioned the data that we need to send back to you. How are community pharmacies actually going to be collecting that data? Is it through farm outcomes, and how do we send that data back to you?
Could I step in and answer that one? So
Please, yes.
Steeping Jan's and Helen's colleague. Yeah, at the moment that has been the source of issue in that the process hasn't been automated. For most services, obviously, as you understand, that are provided by farm outcomes, data return happens under the hood. At this point, it's possible for a contractor to, through their SCS module, actually produce an outcome pro forma with all the data that's required in the form of a PDF and email that back to the trust. What we're working on, or what NHS England and our team are working on very hard at this point, is to automate that process so that it will happen under the hood, and it will happen at each data capture point. So there are 3 trigger points within the 12-week process. There is the 5-day trigger point, which is has the contractor been able to contact the patient, and has the patient agreed to translate the referral into a supported quit attempt. That's point 1. The second point is at 28 days. That's particularly important because that's the data that NHS Digital require from the trust. And then the final one is it's up to 12 weeks, but basically the final consultation. What we're hoping is that very soon that process will be an automatic return via the system, as opposed to a contractor having to actually do anything to generate that return of data to the trust. But at this point, it needs to be done manually, and unless the trust is using farm outcomes to actually make the referrals, at which point they can log in and track its progress. But we will hopefully get that resolved sooner rather than later.
From a pharmacy contractor's point of view, it doesn't seem joined up, because we've got enough things that we are doing, and it would be great if farm outcomes captures the data, it goes to MYS, we submit the claim with MYS. That would be fantastic.
I quite agree. I couldn't agree more.
There are several other processes besides smoking cessation that doesn't capture the data for community pharmacy. And I know you mentioned that it's going to be very soon. However, it would really help, because I know the go live date in Lancaster Morecambe is the 12th, which is next week. We had an email that came from NHS England regarding smoking cessation service, and I'm not sure if community pharmacy is actually ready. Especially, I know that I'm not ready because I don't have a carbon monoxide monitoring system or anything like that at all at the moment.
Okay, well, so you've not yet registered to provide the service?
I thought I had, but I'm not 100% sure.
Okay. If one of the things that Mubasher's put into the chat and the meeting chat, and the slides will be available to you after the event, are a number of references, a number of links to certain documents, including the service spec. Now, the service spec itself for the National Commission Service was updated literally yesterday afternoon. From a contractor's point of view, the most important part of that update was the inclusion of pharmacy technicians being able to deliver the consultations. But it does give you the details of each step that you need to comply with before you can actually register with the NHS BSA to have your name added to that list of registered providers.
Okay.
Can I just add to that? Sorry, Steve.
Of course.
So in terms of carbon monoxide monitors, so in the there's actually a technical specification within the service spec. So highly recommend you do read that service spec, and it is included in the useful information at the end of my slides. So there's a link there to that specification. So highly recommend, and it has to also be a monitor that can be used with pregnant women. That's stipulated within the service specification.
Okay, thank you.
Jan, we've got quite a few hands up.
Okay, so
I'm going to.
If you,
sorry, can we pick them off in order if that's okay?
Yeah.
Could I perhaps be cheeky and start with a question that popped up in the chat a little earlier on? And that was from and it's interesting because this is something that we've not come across at all before. But David Rawlinson asked about a GP on discharge, a GP being asked to prescribe NRT. And my sort of response, to paraphrase my actual response, was, well, that doesn't fit with a referral into this service. So if that's happened, I would suggest there's a serious misunderstanding somewhere as to what was happening to that patient on discharge. And the part of the other question was, would the GP themselves be able to refer in? And the answer to that is no. The thing that followed it, and what I particularly want to pick up on, other than the fact that if that were ever to happen, I think it sort of identifies a significant misunderstanding somewhere within the process that would allow that to happen. However, because the next point that was made was that GPs haven't known anything about this nationally commissioned service. And I would suggest that might be an issue. It's not something that our team has come across at all in the past, with over sort of, around 50 live trusts now and all the conversations that we're currently having. But my immediate thought to that one was that potentially comms from the ICB through the LMC to individual GP surgeries and GPs might be the way to resolve that. So it's not something that's even been on our radar, much less asked.
The GP practices don't know about it. It was that the hospital didn't know about it. So in my
I apologise,
in my 4.5 years with working for the CSU, we haven't prescribed in South Cumbria any nicotine replacement products. So what's been happening is the hospital trust asked the practices to prescribe on discharge.
Yeah.
We then refuse and have been referring in to the community pharmacies using the council commission services.
Sorry, I misunderstood. And that's why I think another reason why it was important that we actually had this as a conversation as opposed to within the chat. I suspect that's probably because before the 10th of March last year, this service didn't exist outside of the pilot sites. That might be the simplest solution for that. And there's obviously up and down the country individual trusts, even within an ICB and certainly across an area like the Northwest region, are in very different positions. So if you take the 133 acute trusts, let alone the mental health and community trusts that we're also engaged with, that brings the total to just over 200. We have got just under 50 live of the acutes. We're working with a further about another 30 or 40, which means there are still a cohort of acute trusts that we haven't yet engaged with or who haven't approached us. We are doing things at the moment to try and improve that. So, for example, one thing that we're doing is hosting a series of lunchtime drop-in Q&A webinars, particularly aimed at trusts that haven't yet begun their journey. And I suspect that's probably the reason why you've had that situation in the past, certainly.
Right. So could we have, is there any more questions in the chat?
Yeah,
or
there are. Can I, well,
should we
not within the chat, but certainly there were quite a few people who'd got their hands up. So thank you for your patience. Actually, quite a few people have dropped off, but there's a hand up from Vipul. Am I pronouncing that correctly?
Sorry, no, that's the old hand, which was
an
earlier.
old hand. Sorry, right. So
right.
I haven't got any more hands up at the moment.
Naomi, should we hand it back over to you? Is that?
Yeah, if there's no more questions, we can move on to the next bit, which I think there's just a few more slides. Is this the last one from?
Yeah, this is our last one. My apologies. So just as Rebecca was saying earlier, that's the UHMBT Stop Smoking email address that we'll be using for our referrals. What we've been sort of piloting a little bit at the moment is in the subject field. We've been putting RLI for Lancaster, FGH for Furness General, and WGH for Westmoreland General. It's just for us, really. So when we're looking at those emails, we know which hospital the referral's concerning. It's just to make life a little easier for us. So if you hit reply, just obviously hopefully that'll be on there. And the last bit just above it is we have got a Twitter account that we've set up. Obviously working with chemists and the Quit Squad. What we want to do is engage and promote both your services and obviously raise awareness. Sorry, easy for me to say on an evening. So that's our @CrossBay Stop Smoking Twitter handle, and that's it from us. Thank you.
Thank you very much.
Thank you.
Yeah, some really interesting stats there. Thank you both. So there's just a few bits and pieces that I just wanted to reiterate, really. Most of this has been gone over, but there's just some bits that I'd like to highlight just to support the contractors, really. Again, just to go over that, so the referrals will be sent from NHS Mail to your NHS Mail, which is your shared inbox. So I've just put a small example on there. Obviously, you'll know what it is. It's your pharmacy.fcode@nhs.net. So because this will be your referral will be going to your shared mailbox, you need to be making sure that this is checked regularly. I mean, obviously you'll be doing this anyway, a couple of times a day, 3 times, morning, afternoon, and before you close, regardless of the service. But obviously, if you are registered to this service, please make sure that you are checking it. The acute trust will also put a read receipt onto the referral email, so it's just so they know that it's been received and that it's been seen and actioned. And just as we've been speaking about, referrals will come through from UHMB Stop Smoking at mbht.nhs.uk. So as referrals are coming through NHS Mail, pharmacies will have to create manual reports, possibly using the templates in the spec appendices. So just like what we were speaking about before, it's not manual and it's not going to be done automatically by the system as of yet. So registering for the service, this is what it will look like. You'll do that through MYS, and so it's just a little bit of a screenshot of what the page will look like, just to make sure that you know that you're looking at the right thing. So again, you'll need to submit manual claims for your payment, and the claims for this service should be made monthly via the MYS portal, and claims should reach the NHS BSA by the 5th day of the following month after completion of the SCS. Again, just a little bit of a snapshot of what it will look like. I've highlighted the smoking cessation service registration. I'm sure you're all familiar with this anyway, but this is what it will look like when it comes to claiming. And that is it from me. Do we have any further questions? Just stop sharing my screen so I can see everybody now. There we go. Oh, I think we're all good. So I think there have been a few resources left in the chat from Mabasha, and yeah, I think there might be a few things that have been popped in there from what we've spoken about this evening. If there are any further queries, please feel free, do email me at office@pharmacylancashire.org. I'm more than happy to answer any questions that you've got. But otherwise, I think that ties us up quite nicely in time to go and watch Love Island for those that are interested.
Sorry, we've had a question put in the chat.
Yeah.
So you will get a degree of an answer for that. So one of the questions that's been asked is how many contractors in Lancaster and Morecambe Bay are currently registered. We have a dashboard as a team that we've created, and one of the principal reasons for that dashboard, and particularly the dashboard map, is to allow people to get a visual idea of how registration and implementation are going. It's not the primary source of information of pharmacies that are currently registered. It's there as a guide. But I noted that Mubasha did actually put the link for that dashboard, or actually, no, I beg your pardon, my colleague Lucy Dunn, who's also on the call, has put that link into the dashboard. So if you click on that link, it will take you to our web page, and the thing that you are looking for is the National Dashboard version 2. And if you open up, you can actually drill in, and you can drill down to the ICB level to actually see how many pharmacies and actually who those pharmacies currently are. But as I say, it's a guide, it's not a definitive statement of registration. So we get a weekly update of new registrations from the BSA, and we also get a monthly update of any deregistrations from from NHS England. But they're currently working at the moment to try and remove those pharmacies who actually closed in the fairly recent past. Obviously, you all understand the situation regarding Lloyds, but they're not the only ones. Clearly, some Lloyds are completely shut. Other Lloyds have been taken over by other businesses, either as an ongoing pharmacy or as effectively a new pharmacy contract. So that potentially changes the registration status of a previously registered pharmacy as well.
I think, sorry, Steve, I think the last time I checked the dashboard, it was about 174. So that was as of last month in Lancashire and South Cumbria registered pharmacies.
Thanks, John.
Can I just say that Mark Lindsay from NHS England sent us a list at the end of last week, and across Lancashire and South Cumbria it was 191, and across South Cumbria alone it was 27.
Thanks, Lynn.
Thank you.
Now do we have any further questions or anything else? No. Well, Martin Schofield, is it?
Yeah, hi. Sorry, I didn't get a chance to. I was logged on my daughter's login for some reason. So I'm one of the respiratory advanced nurse practitioners. I'm the team lead at the respiratory team at Morecambe Bay. I just want to thank everyone for the work that we've done with it. I started with the project right at the start of the smoking cessation service, and was quite heavily involved in the sequence 3 to 4 years ago. So it's really exciting to see everything starting and actually coming live after so long. I think we've got a great team with Anthony and Rebecca. I say it's took months and months of work to get this far. So I think everyone's just so pleased they're actually going live and looking forward to working with everybody, really.
Thanks very much.
Much appreciated, I'm sure. Thank you. All right then. Well, thank you so much, everybody, for attending this evening. It's been a pleasure. And like I said, any other questions, we're more than happy to answer them. But take care and enjoy the rest of your night. Thank you, everybody.
Thank you very much. Take care now.
Thank you. Thanks.
Bye-bye.
Bye.
Bye-bye.
Bye.